You're listening to Clinical Conversations, a Journal Watch podcast. It's for the week of August 14, and it's podcast number 53. I'm Joe Elia. This week, we talk with the principal author of a Lancet study dealing with noninvasive ventilation after extubation. Here is a brief look at the two other principal clinical news stories of the week. Use of aspirin after receiving a diagnosis of colorectal cancer is associated with a better prognosis, according to a JAMA study. The effect is limited to tumors that overexpress COX-2, which includes about 80% of such tumors, and the effect is thought to stem from aspirin's COX-2 inhibition. Also, the CDC has updated its recommendations for school closures in the face of the likely return of novel H1N1 this fall. The recommendations de-emphasize closures and stress sending sick kids and staff home, and, especially, separating them from classmates and colleagues as quickly as possible. More details are at podcasts.jwatch.org. Now, on to the interview. You're listening to Clinical Conversations, a Journal Watch podcast. The Lancet has just released a study online about non-invasive ventilation after extubation in patients with chronic respiratory diseases. The researchers studied 100 patients in Spain, most of whom had chronic obstructive pulmonary disease, and were undergoing a trial of spontaneous breathing and, if successful, extubation. After extubation, the patients were randomized either to non-invasive ventilation or to conventional oxygen therapy. Those on non-invasive support showed less likelihood of developing respiratory failure and had better survival at the 90-day mark. Dr. Miquel Ferrer has kindly agreed to talk with us about his work. He is in the pulmonology service at the Thoracic Clinic in the University of Barcelona. Welcome, Dr. Ferrer.
Thank you.
Can you give us a little background? Why did you choose this group of patients for study specifically?
Yeah, because in a previous investigation from our group, which was published in 2006, we did a randomized clinical trial with a very similar design than the present one, but in all intubated patients with risk factors to develop respiratory failure after extubation. Mm-hmm. In that study, which was published in the American Journal of Respiratory and Critical Care Medicine, 2006, what we found is that non-invasive ventilation compared with conventional treatment was effective in decreasing the rate of respiratory failure after extubation, but in the general population, it did not improve their survival. However, even in a previous investigation from our group from the 2003, we had observed that patients with hypercapnia had a worse prognosis, or hypercapnia was an independent risk factor for poor survival. And then we did a subgroup analysis, and we observed that in the patients without hypercapnia, this is without a retention of CO2, they neither had differences in survival, but in the subgroup of patients with hypercapnia, they had even a higher improvement in the rate of respiratory failure after extubation, but also they improved their 90-day survival. This was the background for the present investigation.
You had studied a general group before, and in the general group of patients with respiratory failure, you did not notice this effect, but in patients who had hypercapnia, the subgroup of patients with hypercapnia, you did notice this effect. And so what you did this time was you did a randomized trial in that group of patients specifically.
Exactly.
Okay.
Exactly, in this specific group. You know that subgroup analysis have always concerns in their validity because they are not specifically designed for this, and that's the reason why we performed this second trial focused in this specific population.
Okay. And so the benefits were limited to a specific group, but it's a large group of patients that one sees in your clinic, for instance, isn't it?
Yeah, in our clinic it's a large group because we work in a respiratory intensive care unit.
Yeah.
However, in a general population in intensive care units, the recent series or large series or evolving a great number of intensive care units, these patients may represent around 10% of all patients admitted to intensive care units with invasive mechanical ventilation.
I see.
Around 10% overall.
All right. So 10% overall of patients in the intensive care unit or with pulmonary problems?
No, in general intensive care units. I talk about a multinational study published 1 year ago that involved nearly 400 ICUs from Europe, North America, and South America. That study involved around 5,000 patients. This was a study to assess the characteristic of mechanical ventilation. And among all these ICUs, which I think they can be considered as a mixture of all types of ICUs, patients with chronic respiratory disorder accounted for around 10% of all ventilated patients.
Okay, so chronic respiratory.
I think this is a good estimation.
Okay, all right. So why do you think that it works better than conventional oxygen therapy?
Because in general, it's a constant finding in all studies in non-invasive ventilation that this is effective in patients with hypercapnia. Hypercapnia, in general, represents that these patients cannot eliminate correctly the CO2 their metabolism produces, and this is a marker of advanced chronic respiratory disease. It's well known that patients with COPD exacerbations who are admitted to hospitals or ICUs or intermediate care units, they benefit from using non-invasive ventilation, and it is effective in decreasing their needs for intubations and for invasive mechanical ventilation. In the weaning, there is also substantial evidence that it also works for patients with chronic respiratory disorders and hypercapnia with difficult weaning, and also in this type of patients. These are quite similar type of patients. Some of them did not require intubation and they were managed correctly with non-invasive ventilation. Others had difficult weaning or withdrawal of mechanical ventilation. And this is a group of patients, those with hypercapnia, with very particular characteristics. They have advanced lung disease because their functional, their respiratory function tests show that they have a very severe airflow obstruction. This is what we have found in the present and in the 2006 studies. And probably the presence of hypercapnia means that these patients are not completely ready to sustain spontaneous breathing, at least in a long-term basis, and that the addition of a given period of ventilatory support after extubation may allow them to prevent their failure, the respiratory failure. Probably this is the hypothesis.
Those patients then would benefit from a kind of a weaning away from intubation through the use of this non-invasive support. And is it possible that because they're not intubated, that they have a better chance of not getting the pneumonias and other things that may be complications of intubation? Yeah. Okay.
Yeah, exactly. That's exactly what. In these patients, even we found in a previous study that patients with difficult weaning, when they are left to a conventional withdrawal of mechanical ventilation, they undergo prolonged ventilation with a very high rate, and these patients with prolonged ventilation have a high incidence of nosocomial pneumonia, and this is the reason for their high mortality at short or medium term. In the population that we have studied now, these are not patients with difficult weaning, but patients with advanced respiratory disease, and in these patients the main reason to improve their outcome with non-invasive ventilation is that these patients the rate of respiratory failure after extubation and reintubation in the 2-3 days following the first extubation is very high. And this reduction in the rate of reintubation is, which reintubation is constantly found as a predictor of poor survival, is probably the reason why they survive more than those who undergo conventional management with simply oxygen therapy. This is and this is consistent with previous investigations that have found reintubation as a risk factor for both nosocomial pneumonia and for survival.
And so what do you think that clinicians should do with these patients then? Can you use, would you recommend that they use a non-invasive support right away? Do they need more evidence to begin using this?
We think that now with this study, the evidence is enough because the results of this study are absolutely consistent with the subgroup analysis I have told you previously from our study from the 2003. And what we think is that, or the clear message is that for clinicians working in intensive care units, if they are going to extubate patients with respiratory disease, this patient is tolerating correctly spontaneous breathing, so they can be extubated. But if these patients have hypercapnia, I mean increased CO2 in arterial gases, with just such a simple measure, which is applying non-invasive ventilation during the 24 hours following extubation, they will improve their survival, because this is a subset of patients with a very poor outcome if they are not supported after extubation. So then this poor outcome can be reversed or at least can be significantly improved applying non-invasive ventilation. In the setting of an intensive care unit now, non-invasive ventilation is a standard technique, so it can be applied without major complications, because it is expected that all the staff, doctors, nurses, and respiratory therapists working in ICUs, they are expected all to be familiar with the use of non-invasive ventilation. So this is not a strange or a complicated therapy or technology.
Okay. Well, Dr. Ferrer, thank you so much for talking with us. I know you're on holiday now, and I hope that you'll have a very pleasant holiday, and we look forward to seeing more of your work.
Okay, so thank you for your interest in our work.
You can reach us at 1-617-440-4374, or you can write to J. Elia, that's Jelia, at NEJM.org. You can also leave a note on the website where you can listen to earlier podcasts and get links relevant to the stories mentioned. Just go to podcasts.jwatch.org. Clinical Conversations executive producer is the one and only Adoriano. I'm Joe Elia. Join us next week. Enough said.